Welcome to the So Tell Me podcast, where I talk with fascinating professionals about the work that they do. I am Dr. Melissa Deuter, and today I'm talking with Dr. Sandra Vale about her work as a geriatric psychiatrist and an administrative psychiatrist. This podcast is sponsored by Sigma Mental Health Urgent Care, located in San Antonio and Austin, Texas. Okay, so I'm here with Dr. Sandra Vale. Hello.
Hello.
And it's we're coming at the end of honoring women in the month of March. And so it's a really good time to have this interview. And so I want to talk to you about your career and your education and how you ended up doing what you do.
Yeah.
So that's mainly what I want to talk about. So I will start with the fact that you're a board certified geriatric psychiatrist. And so that means that you went to medical school, went to college, went to medical school, did a geriatric psychiatry fellowship, in addition to all that other training to specialize in the care of older adults. And so so what led you there?
Oh man, that's a loaded question.
It's complicated.
Yeah. And by the way, also happy National Doctors Day.
Oh,
I feel like,
yes.
right,
Yeah.
it happened on a Saturday, so maybe it didn't get as much publicity. You're right, though. I mean, we're coming off the heels of the National Women's Month and the Doctors Day, and I will tell you that, I really didn't have, I didn't come from generations of doctors, right? So
Okay.
that was not the path that was necessarily put before me, right, when I entered into this. And at the same time, when I look back, it's a really beautiful thing. I'd say, well, of course, this is where I would have ended up, right? It was all sort of a building stone. And I say that because I was in college and I thought, oh, I'll do physical therapy. I was, very athletic in that time. And that was my one exposure or inlet into, health and healthcare. And then I did you had to do a lot of volunteer hours. And I thought, is this it? And so I just felt like there was maybe a misalignment there. And again, not really having that, that mentor per se to say, oh, doctor, yeah, like I would do that. But then at the same time, it was interesting because I was doing this volunteer work at an Alzheimer's activity center or a community center.
Oh, wow. And like, how old would you have been?
I mean, I would have been maybe not even 21, right? Like,
Okay.
right. And so,
So you're
it's
there with these
interesting
little
that-
old people,
Yeah.
taking care of them physically
Right.
and like falling in love with the older patient.
Absolutely. And now that was completely on my own accord, right? No one said, hey, do this. Somehow I just found that I was like, that's what I want to do. I just want to volunteer. So that's why I chuckle, because it's like, looking back, absolutely. Why wouldn't I have been anything but a geriatrician per se, right? And so, but yeah, as happenstance comes along, back then, there was not a lot of text messaging. I mean, cell phones were just coming out. We still had the old school communication boards. And I saw something pop up that was like, apply for this mini medical school. And I was like, oh, that's interesting. What's that about? I applied, I got in, I spent about 8 weeks up at Yale.
What's a mini medical school?
I know, right? What is a medical? Well, it was 8 weeks of basically putting on a hat as if you were a medical student. So taking a crash course, like a couple of days of gross anatomy and all the courses that you would do as a medical student.
Wow.
And after that was said and done, and me, I've always been that person that whenever I finally like make a decision, that's it. I'm all in. I'm 110% in. And so I came back and I was like, I'm gonna be a doctor. Now, funny enough, I was a late bloomer because I was already a junior in college. And right, that we had very prescriptive courses that had to be taken to
Right.
move into even applying for medical school.
Right, all those
So I ended up,
prerequisites.
and so for anybody listening out there, it's really the idea of, it's not always a traditional route in, right? Like I wasn't the traditional 4-year college. I ended up taking almost 6 years because then I had to take these extra courses.
Yeah, you have to double
as a
back.
junior.
Yeah.
Just to get to the point of applying for medical school. And then funny enough, go into I think it was my summer before I started, somehow there was some sort of application, you could do some sort of research. I applied, it's just like, let me just cast my net wide, right? And they accepted me for this research, and my research just happened to be with older Hispanic adults that have dementia.
But it didn't just happen to, right? Because you're like drawn there. You're like going.
Yeah, I was, but at the same time, you got partnered up and you didn't know who you were gonna get
Oh,
partnered up
yeah,
with, and
okay.
I just happened to get partnered up with, I believe that he's probably still locally here in San Antonio, a family practice doctor, and that's what he was working on at the time. And so I all of a sudden was in this research space with working out, and I'm Hispanic. So obviously that was near and dear to my heart. And of course, older people and their community dwelling. In other words, these are people that still live in the community and have some sort of dementia process going on. So
Okay.
that kind of started. Going to medical school, and I still remember this. And I think that, don't we have connection around UT Health?
Oh, yeah,
See,
yeah. I did my residency at the UT Health Science
Yeah,
Center. Mhm.
yeah. And I want to say that, fast forwarding to when I was applying for residency, I am almost sure that a young Dr. Deuter interviewed me for that residency position.
That baby,
Our paths crossed early on, so that was,
Okay.
I
That was so
remember
fun
that.
for me. When I interviewed for the residency here, Thomas Matthews interviewed me. And he was so great because he had been a tour guide in San Antonio and he had all this great information. And then when I got my turn and I was interviewing people, it was so fun to just bring them in. And so that's neat. I have so many people I don't remember, but that's neat how you
Yeah.
just weave this web of relationships.
We're all interconnected,
Yeah.
right? And particularly with the work that we do. That's the
Right.
beautiful thing. I think I still remember Jason Schulster, wasn't he part of your class?
Yes,
I feel like I
yes.
interviewed with him as
Oh,
well.
probably,
So
that's
we're
right.
all interconnected. Jason ended up being one of my mentors later on, down the road, but so I digress. So yeah, so I entered medical school, and I remember a huge medical school class, and they're like, we're gonna do this fun exercise, and y'all don't know each other, but who do you think out in this class is going to be the pediatrician and the psychiatrist and the surgeon and the dermatologist? And people picked me for being the pediatrician, right?
Oh, interesting.
Yeah. But then they also, on the flip side, said, okay, what is the one thing that you're absolutely not going to be? And I picked two things. I was like, I'm not going to be a surgeon. I'm definitely not going to be a psychiatrist.
Oh, how
right? So
funny.
mark my words, right? And so then fast forward, we head on to rotation time. Now, I was actually I was the inaugural class for what we call the Regional Academic Health Center. So it was 20 plus of us that were somewhat volunteered or voluntold, for the ones, because I was a volunteer, but we still had spaces, and I was like, someone's gonna go. So some were voluntold, you're gonna go to Harlingen and you're gonna do this new experience that no one's ever done before. We did our clinical rotations out there. So my third year I'm out there.
And how far is Harlingen from San Antonio?
Yeah, so from a drive perspective, we're talking 4+ hours.
And from the border of Mexico?
Yeah, border's just right across. Right?
So
Yeah.
it's right there.
It's
So you're
right
in this
there.
border town.
We're a border town. And now at that time, there was no residency program per se. So it was just an attending physician and these new medical students, me being one of them, for clinical rotations. So we got more than hands-on. I mean, I was there doing, assisting, doing first assist for surgeries.
Wow.
And I was not delivering placentas, I was delivering babies, right? And so very
Yeah.
different experience from my counterparts that stayed in San Antonio. But I got about halfway through that year. And so for those of y'all listening, your third year of medical school, it's when you do all your clinical rotations. And that doesn't matter what kind of doctor you're going to be, you all get exposed to different areas, including psychiatry. I was already more than halfway done, and I thought, this is not good.
I'm not
So
finding
far,
what I
I
want.
don't like anything that I've done. I
Okay.
kind of thought, oh, maybe family practice. That came in when I was like, nope, I'm not excited about this. So I was getting a little worried about what am I going to do with the rest of my life, right? I'm already really embedded in 2 years have already passed. And
Right,
it's money.
Yeah, and again, for people watching, I mean, it's 2 years of classroom work, and they don't always do it that way anymore, but it can be 2 full years, and then you go to a full year of rotating clinical specialties,
and you get in there and you're looking for something you like, you have a huge investment. You've done college, pre-med, med school applications, MCATs, the whole 9 yards, and 2 years of med school.
And
then
there's money attached with that.
lots of money. And you can get in there and say, like, I don't like what I'm doing.
Yeah. And it's a really tough place to be.
Yeah.
It doesn't feel good.
Yeah.
And what I had left is I had psychiatry left, OBGYN left, and surgery. Now, remember, I just said that no matter what, there were two things I was not going to be. I was not going to be a surgeon. I was not going to be a psychiatrist. So you can imagine how I'm feeling right about now.
Like, I hope I like delivering
I don't feel
babies.
very, very good about this. But I did step in day one of my psychiatry rotation. And with psychiatry, along with all sorts of other specialties, but with psychiatry, you don't necessarily start off in an outpatient clinic setting. You could start maybe in an inpatient.
Right.
For me, I got paired up with a somewhat private psychiatrist in his outpatient clinic. So it's day one, I'm going there, okay, I'm gonna give it my best go, even though it's absolutely not what I'm gonna do. And they're meeting the psychiatrist. We get settled in. The front office staff walks in and says, okay, well, your first patient's here and she's out in the lobby and she's reading the newspaper. And the psychiatrist and I are like, well, okay, thanks for telling us that she's reading the newspaper. I don't know that we really need to know that.
Why is that important?
Yeah. But no, it turns out, so she came in and she wasn't reading the newspaper. She was eating the newspaper.
Oh, no.
And that was it. And I was sold. And like I said,
This is the strangest thing I've ever seen. I am fascinated.
And I am fascinated and intrigued, and I will never have a boring day in the rest of my career, right? And I was sold. From that moment, I was sold. And like I said before, there's the theme here is that once I decide something, I'm all in. I'm 110% in. I was 110% in. I remember after that first appointment, I told him, I said, I'm going to be a psychiatrist. And he's like, well, hold on. He was an East Texas kind of psychiatrist, had a real thick accent. He's like, hold on, little missy, like, this is just your first. And I'm like, no, you don't understand. This is who I am.
And it's built to this. This is
what I.
The story is not just a moment; it's the whole experience.
Yeah, and it was, and I was all in, and it was so different from those book years. That was one of the reasons I thought I'm not going to be a psychiatrist. I can't memorize all these medications and these drugs. It just seems so foreign, and there was nothing tangible for me. And I'm such a tangible, hands-on person, but the clinical part was different, and then it made the book stuff make sense, right? So as they say, the rest is history in that regard. I ended up pursuing psychiatry. And then of course I met you as I was on the journey for which residency program am I going to go into?
Yeah. And so then did you know going into residency that you were going to do a fellowship or not yet?
No.
Okay.
Well, no, I backtracked because I thought, okay, I'm going to do, which is weird that I kind of thought it, of course, thinking back to the exposure I had to older individuals, but I was like, I'm going to be a child and adolescent psychiatrist.
Okay.
So in that regard, yeah, I felt like I was going to do fellowship for child and adolescent.
Okay.
And I soon learned that that was not going to be my cup of tea.
Okay.
Is the other spectrum, the other end of the spectrum. So then there, and I got matched up for Galveston. And I was like, wow, well, that life's going to be interesting. I'm going to be working on an island, right? And so really, what an amazing experience. And I always tell, medical students that I work with, that if I had to do it over again, there's only one thing I would probably want to try to do differently, and that is to go to medical school at Galveston, because I had just
It's a great place.
experience.
It's a wonderful medical center at Galveston. It's really, really wonderful.
Yeah.
And so I'm a fan, and I didn't go there. I didn't do any of my training there, but it's just a really neat place.
It's different.
It's different.
And you still get the work done, but it's in this very laid back, like, are we really doing work kind of fashion? It's interesting. Things still roll, but they have this, it's a different cadence. The different cadence to it. And people don't really wear white coats out there because it is an island. You'll see a lot of like flip-flops and Hawaiian shirts, believe it or not. And particularly with psychiatry, you're like, well, who's the doctor? So it was just it was not the academic field that I was used to in San Antonio, right? But as things happen, and it's always like, just don't, I think for the audience, it's realizing like, don't ever pigeonhole yourself, right? Always, because doors will come and go, but don't be the one to close the door on yourself. And I think that was the big overriding theme for me, because I was doing a lot of that, like, I'll never be a psychiatrist, I'll never be a surgeon. And I was closing the door on myself, right?
Mm.
And then same thing with, well, what am I going to make out of this, right? And I thought, well, child adolescent, I'm going to pigeonhole myself in child and adolescent psychiatry. And I soon found out, no,
You didn't like
no, no.
I didn't either. I like adolescence, but I really didn't want to do, I didn't want to prescribe medication in particular, or provide
Mhm.
like what might be a long-standing diagnosis to a little child. I feel like there are people who are wonderful at that. It was not a comfortable or desirable space for
Yeah.
me either, so I understand.
Yeah.
And
And
I
then
thought,
ironically though, but like, what is it that you do?
right, I see a lot of
So,
adolescents. And
yeah.
so it's interesting because you like part of it and then you get into it and you actually do it and you say, oh, no, this is
Mhm.
not fitting.
And at the same time, I mean, in terms of now, also again for the audience, when you go into psychiatry residency, even if you do general adult residency, you're still going to have exposure to child and adolescent. It's just part of that training.
Right.
And so that was really amazing, because at that time, Galveston was kind of that premier hub for child and adolescent psychiatry. I mean, we had the Dr. Wagners of this world,
Yes,
right? And so
yes.
really got a nice exposure. And for me, it worked in the sense of realizing, no, I really don't want to do this, right?
Mhm.
And it was really more about, from what I align with that, with what you just said. And also the idea that, a lot of it was the family, it was the
Right.
parents.
Right.
And that takes a lot of more of the therapy piece of it. And so it just didn't really gel with me.
Right. And I'll say a lot of it is, trauma, problems in families. And you in the role, if you're a child psychiatrist, are not necessarily the one getting to try to solve the part that needs the most work.
Right, you're just
You're there, there's a therapist on the team, but you're not getting to do the piece that's the most healing. You're relegated to this diagnose,
Mhm.
make this medical plan, and the medical plan is not central in the
Right.
way that it might be in other areas.
Yeah,
So
that's a really good way to capture it. Really good way to capture it. And, so again, that whole theme of don't close the door on yourself. So what happens, psychiatry residency general, it's 4 years. So by third year, I was an assistant chief resident. And then fourth year comes around and I was going to be the head chief, right? The chief resident. And then life happens again. This is the theme, but again, I feel so strongly. There's no accidents. There's
Right.
no accidents. There's always that bigger, stronger purpose. What happened was hurricane, because we are in Galveston, are we not? Now, I was born and raised in San Antonio, Texas. I have no idea. I had no lived experience with hurricanes. I was like, I'm so out of my element. We already had a couple of trial runs, if you will. So it's interesting because, for any medical students that are out there listening, I mean, in terms of disaster medicine, that's a place to consider. Because when there's any threat of like a mandatory evacuation, yeah, everybody evacuates and you still have a hospital to run. And so there will be people, medical students, residents included, that have to be part of that team. That the hospital has to remain in some capacity, right? So you think about back to Hurricane Katrina, and you can think about those first responders and people that had to stay there, and
Right.
they were
And also
front lines.
like Katrina, then a lot of those people were brought to other cities, including San
right.
Antonio. And you have the disaster efforts here in San Antonio
Mhm.
to receive all these people. Some of them are injured, traumatized. So you have disaster relief that's happening in all these different hubs for a
Yeah.
big hurricane too. So yeah,
Yeah.
it's a whole world.
And
of
so that was
practice.
something, again, even when I was in my assistant chief resident year, I mean, part of being an assistant chief and a chief resident is that organization. You're trying to organize all the residents. So there was a lot of organization and planning, and some of it had to be very quick because, I mean, you don't get a month heads up, that a hurricane's coming in. It's like couple days, and you've got to make this happen.
Right.
And so it was a really interesting exposure there. But as it were, my chief resident year, we had a really bad hurricane. Hurricane Ike came out and wiped out our hospital,
Wow.
wiped out our teaching hospital. All of a sudden, we didn't have a place to train. And it was really sad because for any of you that you guys know about, residency per se, your intern year is when you pretty much live in the hospital. So it was our interns that mostly lived on the island directly because they had to spend the most time at the hospital, and many of their residences were destroyed. So not only did they have a destroyed teaching hospital, but their own personal place of residence was gone.
Wow.
So talk about just layers and layers of grief and change so quickly. And all of a sudden, my chief resident year became an administrative psychiatry year. And the rest becomes history, because from then on out, it really became the platform. And I did not know it at the time, but became the platform for what has turned into a career of administrative psychiatry. And
Yeah.
who knew?
And I
Who
think
knew?
people don't know about administrative psychiatry. This is interesting because you ended up, where's the fellowship in that? First, the fellowship. You ended up doing the fellowship in Geri Psych. Where did you do that?
Yeah, so that administrative psychiatry year, I had a calling, and I think maybe it was because I missed some of that clinical psychiatry that last year, right? It was like, there were a couple of things that factored into it. One is, we know, it's no secret there's an aging population. So the
Right.
reality became, yes, I am going to be a general adult psychiatrist, but whether I like it or not, a general adult psychiatrist is eventually going to be a geriatric psychiatrist,
Right.
whether they want to embrace it or not. And so that, what, let me just call the bluff and I'm going to embrace it. Why not? Right. And so that was the first thing that factored in. And again, I think it's also because of the impact that I had from a very different year. And so I said, what's another year of training? You're never going to go wrong, especially if I know I'm going to be a general adult psychiatrist that needs to feel comfortable working with older individuals. And so that's what really went into my decision to do an extra year of training. Now at that time, and I think it's still true, there's only 2 geriatric psychiatry fellowship programs in Texas. We're kind of like dinosaurs a little bit. So San Antonio and then in Dallas. And so, yeah, of course, no brainer. I was born and raised in San Antonio, still have my family here. So it's like, I'm gonna come back to
Some
San Antonio.
incredible teaching faculty. I mean, I was so I consider it a great honor and privilege to have trained here in San Antonio. Not only is there a child psych fellowship and a Geri Psych fellowship and a diversity of experience in military and so forth, but those Geri Psych teachers like Don Royal and Jeff Cordes, they're just brilliantly wonderful teachers. And I was in awe in training with them. And so I can understand if I had the choice in Texas to go to those 2 programs. I don't know anything about Dallas, but I would be drawn to those folks because they're just giants in the field of geriatric psychiatry.
Absolutely.
So,
and for, really for any psychiatry residents that might be listening to this, it's really something to consider, right? You're never going to go wrong with an extra year of geriatric psychiatry, because what? It reminds you that you're a physician first and foremost. You rule the general medical condition out first, right? You don't forget. In fact, you hone in on those physical exam skills. I think another thing that's really important, in fact, I was just talking to the students today about it, it was the fact that, again, because we are an aging population, if I were in an academic-based role or a teaching based role for medical students, residents, etc., I don't care what type of medical what type of resident you're going to be. At this point in our society, we really have to have everyone exposed to nursing facilities, group homes, skilled nursing facilities. I mean, that is where our population at large is moving to,
yeah.
For better or worse. And there's just so much intangibles there. So that's the other thing too. I mean, and of course, being psychiatry and you do a geriatric psychiatry fellowship, you'll have significant exposure to nursing facility care, right? Along with even things like, that's where I did adult protective services evaluations.
Okay.
A lot of those APS evaluations are for older individuals, and it really becomes a perspective of self-neglect per se, right? That maybe they've got a cognitive issue that's brewing, that's not allowing them to take care of themselves in a way that is healthy or safe.
And then you need to put them in a place somehow where someone else can be in charge, so they can be healthy and they can be safe. I've had situations just in that regard for people who don't realize, like, for example, an aging woman who was in cognitive decline, beginning to get confused, and was kind of paranoid, and she was sleeping in her car. She was not eating,
Yeah.
and she lived alone. So the neighbors call and the authorities get involved, and then Adult Protective Services, and a series of things happen to get her placed somewhere where she can be safe, because this is an unsafe situation, but she lives alone and there's no one who knows how bad this has gotten.
Yeah.
So yeah, it's really
These are
important.
things, right, that happen. So, but yeah, no, and I will say, I'll clarify for the record. So that year that I did my fellowship was a year that, you don't, there's boards that you have to take to get certified. The boards were happening that year, but because I was finishing my program that year, they would not allow me to sit, right? That's the way it works. You have to be completely done with your program before you can sit for the boards. And those boards only occur every couple of years.
Right.
So I missed my opportunity to go truly get a board certification simply because I hadn't taken that test. I am what we would consider board eligible.
Okay.
Which means that I can go and get board certified because I've done a training program. Just, haven't necessarily taken that formal step, right? And of course, in talking to geriatric psychiatrists, they say, like really, at this point, there's even geriatric psychiatrists that are board certified that have kind of like let go of that
Right.
recertification, because it's like, it doesn't matter at this point. I mean,
Yeah.
it's like drinking from a fire hose in terms of the need right now with our growing population.
Right.
And so I just
Yeah.
wanted to clarify that, because I think
board
that's important.
certification is it's an interesting animal, because you need it for certain credentialing.
Mhm.
You need it to get on, certain panels with insurance or with hospitals or things like that. But for a lot of the work that people do every day, well, that's a whole nother, we're paying these exorbitant fees. It may not really inform anything about what you do. Your training's still there. You still, you have to do your continuing education anyway. You have to stay licensed. You have certain things to do. And so, yeah, it's interesting, because that is, it's a growing, brewing change, I think, in the field of psychiatry, whether people really think it's worthwhile, because it doesn't inform a lot of what folks do. So
yeah, I mean, I would certainly say for your general certification, right? That makes a lot of sense still. Like you said, there's a lot of layers to that, it's another hoop to jump through, right? So being board certified kind of helps with that. On the subspecialty side, which is what we would call like our geriatric psychiatry, child and adolescent, addiction psychiatry, things like that. We would say that that's a subspecialty, if you will.
right.
And those, that's where I think the tide's turning a little bit in terms
Right.
of, does it really help to be board certified?
And then you have to certify in two different ways. You have extra work to do to,
Exactly.
it's
a lot.
money to pay and
Money.
hoops to jump through. And
Yeah.
no, absolutely.
And so that's, that led me to that 1 year of extra training, in geriatric psychiatry. And then before I knew it, with my administrative psychiatry background, now it's time for me to, go look for a legit job, right? Like my first job out of training. And it was so interesting. I had no idea how much overlay there was with not just being a doctor, but being a doctor that has some administrative background. I did not even know. So all of a sudden, now I think I've learned my lesson, right? I'm not closing the doors on myself. Just quite. I found there was a position that was available, and they said, well, we really want you for this position. I said, don't you guys want, and again, me closing the door on myself, don't you guys want a child and adolescent psychiatrist? Because it was at a state supported living center. And we have these, this was formerly known as state schools. And my concept of that was, there are individuals that reside there, right? So they can't be fully immersed in the community for whatever reason.
Because they have
but
some very serious disability, disabling condition.
Right, and we would call that, so they have an IDD component, so that's that intellectual developmental disability. And a lot of times with that, for these individuals that have to reside in the specialized care place or center, a lot of complex medical, overlay and so forth. And of course, from a psychiatry perspective, these are individuals that have been at the highest levels of care, which we would call the state hospital.
Mhm.
So not just a psychiatric hospitalization, but a long-term psychiatric hospitalization, which is at the state hospital. And so again, I just felt like, well, that's child and adolescent, isn't it? It's like, well, no, because we have all this older individuals, so here we go, older
Mhm.
individuals that can't be placed anywhere
And they have conditions that they've had since
since
childhood,
childhood.
but they're also aging and they have these medical problems that come with age. There's a whole medical complexity to
Right.
that population.
And so they were really purposeful in saying, actually, we kind of think we want someone with your skill set, someone who's been trained in geriatric psychiatry. And it's like, oh, okay.
Okay.
And so there, the rest is history. So from day one, being out in the workforce, I've had, again, this really largely built out in administrative role, meaning that I've never done 100% direct patient care,
Mhm.
right? I've done, so in other words, my work would be that, yes, I still see people for that traditional direct patient care, but then I've got this other stuff that I do, right? This administrative stuff.
Yeah.
So when I entered there, one of the big administrative things that I was doing, because I came into a directorship role. So I was the director, for psychiatry for the whole state supported living center. And they were and I think they still are, under a settlement agreement with the Department of Justice.
Okay.
And it really came because of these individuals being what we would say over medicated,
Okay.
a lot of medications. And so the Department of Justice stepped in and said, you guys have to do something to make them as functional as they can be, which means they can't be snowed under
Yeah.
and asleep all day long.
And in
right?
other words, you can't just because somebody has meltdowns twice a week, you can't just sedate them all the time.
Right.
Yes, you have to deal with people who are having problems like that, but you can't do it in this way.
Yeah. And so that was the big premise. I know that there were some other
Mhm.
offshoots, but yeah, so that kind of started, this whole journey with administrative psychiatry. And of
Mhm.
course, like I said, looking back, it's like, well, why wouldn't I have been doing this, right? With the
Mhm.
exposure that I had. I also say, I think it was when I was in college, and maybe I think I had already determined, yes, I'm going to be a doctor. And I decided I want to work with hospice. And so I did.
Mhm.
And that was actually a paid job where I worked as a care aide in a hospice setting. And so again, all these wonderful things, I can look back and say,
Oh,
wow,
well.
everything I've done really led me and gave me this other skill set. Because I think a big part of being a geriatric psychiatrist is the idea of team.
Mhm.
You don't really work alone per se. When somebody comes in to see you directly, it's typically not just that person, it's their whole family and support system.
Right.
And you have to understand and know and navigate through that. If you're working in a nursing facility, having that connection in with what the nurses do. I mean, the nurses, in fact, I was just telling one of the students, if you're in a nursing home setting, it's not the doctor that rules the nursing home. It's those nurses.
Right, they're there
Because
much more.
they're consistently there.
Right.
It's the workforce that's consistently there. So being able to really connect in and like, I know what that care aide does because I was a care aide once upon a time, right?
Mhm.
And so it's really been an amazing journey from that regard, that I can say, oh yeah, I've worn that hat. I know what that hat is like,
Right.
absolutely. And now I wear this hat and I have a respect and a regard for that.
Yeah, and
hat.
let me say something about the administrative work. So, I mean, you're doing largely your primary role now is administrative, and your smaller role is clinical. And I
Mhm.
think among physicians, it's almost like, at least as I came up in training, like frowned upon. But I think physicians need to be in those roles. A lot of the administrative leadership is done with other kinds of healthcare professionals, and there are fewer physicians, and we need physician leaders to come in and help design how systems work, create regulations, make sure that they're sensible for physicians who are
Right.
delivering care. And I think sometimes when you have people who have never been a physician, they've never delivered care, and they're developing regulations and systems, they may not really understand what they're doing fits or doesn't fit within the system. It's such important work.
Yeah, and you're so right. And I knew that, some of these areas of administrative medicine being frowned upon. And
Yeah.
then you realize, well, why were they frowned upon? So it's a spirit of inquiry. Well, maybe because there wasn't physician representation, right? There wasn't a clinical presence. And so I feel like I've always been in that, oh, I'll do whatever anybody else doesn't want to do, right? I feel like geriatric psychiatry is a calling, and this administrative angle is also a calling, right? You don't necessarily get accolades and respect and regards from your peers. And when you move into this realm, you don't necessarily get the same level of regard as a physician does in a regular physician community, because you start moving into more of this business side, and it's business.
Right.
And you're just another person. You're not necessarily a Dr. Vale even for a lot of this stuff. But it's realizing that it was frowned upon for so long because there wasn't a clinical voice at the table. So, what I always like to tell my peers when it's like this, you turn to the dark side, for instance, like with
And I bet
with
they say
insurance
that.
work.
Oh,
Yeah,
you've turned to the
absolutely.
dark side. Yeah.
Yeah, I'm like, you want me on the dark side. You want me to infiltrate the dark side, right? I want to work on y'all's
Mhm.
behalf to make it better so there is a clinical voice. Because
So
so
the-
many times it's non-clinical people making
Right.
clinical decisions. Now,
Right.
how does that ever make sense, right?
So then people get the impression that the folks who make those administrative decisions have no idea what goes on. And here you are trying to make sure you've got a foot in each camp.
That's
So
right.
you know what goes on so that you can make informed decisions. So,
Right, right.
yeah.
And many times when I have these discussions with doctors now with the work that I currently do, I'm like, I get it. I'm right there with you. And we ourselves are trying to fight this, and this, right? It's a regulation that is not created by, the insurance company per se, as an example, but it's one that we have to abide by. And yeah, you're right. It doesn't make sense. And we are trying to work on the background to make it make sense clinically, right? Well, if there's not a Dr. Vale in those systems,
Right.
then there's not representation for us as a physician group.
Right. I think that's right.
So yeah, I think all in all, it's funny because so over the years, I started with that state supported living center role. And then I moved into kind of more of like a pure geriatric psychiatry role, but it was integrated care. It was integrated care before that was like a buzz term.
Integrated with primary care.
That's
Okay,
right. That's
okay.
right. Yeah. Like we were kind of like the pioneers. It's like there wasn't a lot built out yet. So that was kind of cool, and it really became an experience of trying to fly the ship as you're building it.
Yeah.
Well, I love that because with the work that I currently do administratively, it's always trying to build the plane while you're flying it. There's no rule book for this, right? Because like I said, for so long, there weren't physicians at the table. So it's kind of like this open slate, and it's being comfortable with being uncomfortable. It's being
Mhm.
comfortable with living in the gray zone because there's so much more that needs to take place to make, again, this makes sense for the population at large, right? And so, yeah, so I love that, every experience kind of led me to that. Even right before I moved into this current role, I was at what we call an MHMR. That would be the Center for Healthcare Services in San Antonio. And so that's working with the seriously mentally ill. And of course, again, yes, I had more direct patient care, but a lot of it was overseeing the largest department, which is adult behavioral health for the center.
Mhm.
And it's a lot of administrative. And then you start getting into, financial.
Yes.
And that's not the stuff that we learn about in
Right,
medical
that's
school,
right.
right? And yet it is the way of the world.
Right.
So it's about finding our way in to, yes, of course, we have to talk numbers, right? But always having someone who's at the table, and that's my onus. That's a compass I carry to represent, okay, yes, I hear that. And remember the patient experience, remember the member experience, right? Remember the provider experience, right?
Right.
And
Because
so
if
that's
you
really
just
important.
burn through all your providers and squeeze all the work out of them that you can get, and they leave and you start over, this is not good for patients. This is not good for the profession of medicine. This is not good for anything.
And you really hit on something, which is exactly that, because for so long it was like, well, we'll just keep recruiting. I'm like, well, that's the definition of insanity, isn't it?
Right.
Right?
What about
Because-
retention?
Yes, exactly. And so it was really about trying to shift the culture into saying, maybe we don't spend all of our time on recruiting. What can we do to retain some of our workforce here, right? That we get a little bit of traction, because every time there was turnover, then you're kind of starting from square one again. And guess who ends up missing out? It's that patient
Yeah.
and that patient experience. And so, yeah, I think, and what I really feel blessed is the fact that I still have the opportunity to do direct patient care.
Yeah.
There's
So
there's
just a minute
true-
on that before we wrap up. So
Yeah.
you do your clinical work here at Sigma,
Mhm.
and I really appreciate, I'll tell you, one of the things I appreciate about your clinical vantage point and your teaching vantage point is just how much hope and reassurance you instill into it. Like, we're gonna figure this out. This is okay. I really appreciate that. That's such a geriatric psychiatry stance, right?
Right,
And
right.
like, it's okay. We're gonna do this together. We're all gonna figure it out. And so, how long have you been here now?
I think we're going on, as of just this past month, we're at the 8-year mark. It's been
What?
8 years.
What? That can't be right.
Yeah.
And you know, it's a small clinical commitment, but it
Mhm.
has a wide reach. You're teaching our medical students, you're
Mhm.
doing a teaching every week with our team
Mhm.
and focusing on some of those geriatric psychiatry points,
Yeah.
bringing in your administrative knowledge and just, teaching us just a lot of things that you enrich our team. And so
Thank you.
we love having you here. We love being able to consult with you and pick your brain in
Yeah.
different ways and have you see some patients that you can advise that are complex or, have unique needs, people who are on 20 meds and they're 80 something
Yeah.
and they come in and somebody says, "Oh, Dr. Vale, can you take a look at this and tell me?"
Yeah, give it to me, yeah. Well, and I tell you, the gift has been all mine, because you were the one that, said, well, this is gonna be different. It's not the typical clinical, it's not even a part-time thing, really, right? But this is where I'm at, right? And like, open doors, yep, we'll figure it out, we'll make it work. And we have, and I mean, things have shifted a little bit over the years, I mean, it's been 8 years, hasn't
Yeah,
that? So,
yeah.
yeah,
And
but somehow we
COVID
made it
and
work.
post-COVID
Yeah,
and
that's right. We've done
telehealth
that.
and all
We've
of
done
it.
that.
Yeah, yeah.
And I think what I really love is being able to work with all the different students and the practitioners, right,
Yeah.
that come in, and helping them to understand that, particularly for the students, residents, your job right now is to learn the book, learn it so well, because when you get into clinical practice, the person in front of you is not going to be the book.
Right,
They're
right.
just not. I can count the number of times I'm like, oh yeah, this is pretty much completely by the book. That's just, particularly for older individuals, it's not the book.
Right,
And
right.
you have to be willing to, again, have a wider view of what's coming on before you. And I will say that, every doctor is also still a patient. I mean, I have my patient experiences, and I'm like, oh man, that was a big miss. I see it all the time.
Right.
Our healthcare system, which is like, well, I'm, saying something, it's like, but that's not what your report says. Like, but I'm the person in front of you, and this is my experience. And I think when it's all said and done, in terms of that geriatric psychiatry extra year of experience, it was about realizing that, yes, you always go back to general medical condition, and it builds out your listening skills. If
Yeah.
you listen, and you listen well, and you do that one thing, people will give you what it is that you need.
Yeah, you got to learn how to
You
listen
have
to
to
them.
learn how to listen. They will give you the roadmap, because the end of it all, we do have a bit of a roadmap, right?
Right.
For our own selves. And then bringing the doctor in, the doctor says, oh, okay, yeah, you're telling me all this. Oh, yeah, that is, X disease or whatever, right? I remember the other day I was watching something with the kiddos, and this person had a situation develop, and I was like, oh, I think it's that condition. Like, Mom, like, how would you know that? I'm like, well, he's giving you the road, right? He's giving you the roadmap. So actually was Guillain-Barré syndrome. For
Oh.
those of y'all that are medical watching this, yeah. And all it was that he one day woke up and he was clumsy on his feet. And by the time he reached the emergency room, he couldn't even stand up. And I was like, oh, that's ascending paralysis, Guillain-Barré until ruled otherwise, right?
Right, post-viral.
But
and
funny enough that, you know, the treating team didn't clue into that for a while.
Interesting,
You
because they
know?
didn't follow the story. And that's, I think, yeah, like Jerry Psych teaches you to like take those life histories and follow the trajectory and like
Mhm.
you walk along with them through their story
Mhm.
until it kind of reveals itself how this thing unfolded, and that's where you find the
Yeah.
answer. And you can't go in with a checklist,
Right.
right? You can't do a spot moment in time with your list of symptoms. You
Yeah.
have to say, well, which came first and how did it unfold and what was the order and the trajectory and the severity and everything else? Were they
Yeah.
depressed first and then there were problems with their memory? Or
Right.
did the memory problems come first and then they started to get depressed? Like that's two different animals, you know?
And again, with our older folks, you get a lot of noise.
Yeah.
You get a lot of noise. And so that's, again, goes back to that really important skill that you learn is just listening.
Yeah.
Listening, getting out of your own way to really listen to what that person is saying, because they will say it, they will tell you what it is, right? In this case, the treatment team got sideswiped because it was like they found out, well, this person was using drugs. Like, oh, it must be drug related. Right?
Yeah,
And then they
tangent.
forgot the big elephant in the room, which is this person had an ascending paralysis, right? So I just use that as an example of, you know, what it means to be in geriatric psychiatry. And I think what we can bring to the table in terms of, you know, the next generation of practitioners. And I say that because it's not, you know, we know that physician is a small workforce these days. The practitioners we have those advanced practice practitioners, you know, so that's our physician assistants and our nurse practitioners. And we know, and that it absolutely is a big part of, you know, Sigma's, you know, treatment team that we have here. And so it's about extending those pearls of clinic, you know, being clinical to all those different practitioners.
And being a team and
Mhm.
sharing the load and consulting with one another
Mhm.
with our various kinds of expertise and our
Yeah.
various roles. So, okay, I could talk to you probably for a whole nother hour, but we'll wrap it up there. And I
Sure.
thank you. This has been wonderful. This is a lot of fun. I learned a lot of things about your journey that I didn't know. And I think it's really interesting for folks
Yeah.
listening and for our students on our team and everybody to hear about how you got to doing what you do. So thank you so much.
Yeah, you're welcome.